Bronchiectasis. What is bronchiectasis? It means permanent destruction and dilation of the bronchi proximal to the terminal bronchiole. Clinical feature. The symptoms include cough, which is chronic, daily, and persistent. Then sputum is copious and continuously purulent. Chest pain occurs due to pleurisy. Hemoptysis, infective exacerbation, which is manifested by increased sputum volume, fever, malaise, and anorexia. Halitosis or foul smelling breath is associated with purulent sputum. Poor general health such as weight loss, anorexia, exertional dyspnea may be present. The signs are clubbing. If condition is mild, there is no chest finding. Coarse crackles may be heard over affected area. Collapse due to blocking of bronchus by secretion may lead to diminished breath sound. Advanced disease may lead to scarring and associated with overlying bronchial breathing. Investigations include chest X-ray, which shows bronchiectasis unless very gross. In chest X-ray, bronchiectasis is not usually apparent on a chest X-ray. In advanced disease, there is thickened airway walls, cystic bronchiectic spaces, and associated areas of pneumonic consolidation or collapse may be visible. In high-resolution CT scan of chest is thickened dilated airways is seen, and this CT scan is much more sensitive. We also do sputum examination for microscopic examination and culture. In X-ray of paranasal sinuses, 30% patients have concomitant rhinosinusitis. In serum immunoglobulin, 10% of adults with bronchiectasis have antibody deficiency, which is mainly immunoglobulin A. Sweat electrolytes are checked if cystic fibrosis is suspected. Assessment of ciliary function is done by assessing nasal clearance of saccharin. Treatment. Principles of treatment are chest physiotherapy, which means postural drainage of sputum at least 3 times daily for 10 to 20 minutes. Antibiotics. The appropriate antibiotics are the same as those used in COPD, such as aminopenicillin or a macrolide. Co-amoxiclav, where beta-lactamase producing organisms are known to be common. Antibiotic therapy should be guided by microbiological results. For Pseudomonas, oral ciprofloxacin 500 to 750 mg 12 hourly or ceftazidime by intravenous injection or infusion 1 to 2 gram 8 hourly. Bronchodilators are used, and anti-inflammatory agents such as oral or inhaled steroids are used. Surgical treatment includes excision of bronchiectatic areas if only indicated in a small proportion of cases, usually in young patients in whom the bronchiectasis is unilateral and confined to single lobe or a segment on CT scan. Difference between pulmonary tuberculosis and bronchiectasis. The cause of pulmonary TB is Mycobacterium tuberculosis, and the cause of bronchiectasis is the complication of tuberculosis and cystic fibrosis. In pulmonary tuberculosis, sputum is not purulent, but in bronchiectasis, sputum is purulent. In pulmonary TB, clubbing is usually absent, but in bronchiectasis, clubbing is present. In pulmonary TB, features of consolidation over the affected area in chest is found, but in bronchiectasis, coarse crackles and features of collapse or consolidation is found in the chest. In pulmonary TB, there is single or multiple radio-opaque shadow in X-ray, but in bronchiectasis, cystic bronchiectatic lesions or honeycomb appearance is seen in radiology. In pulmonary tuberculosis, impairment of lung function is less, but it is more in bronchiectasis. The treatment of pulmonary TB is anti-TB drug, and the treatment of bronchiectasis is chest physiotherapy, antibiotics, bronchodilator, steroid, and surgery.